Good morning. I would like to share this joint work space. Besides being important, it is necessary to look at the goals that we have set to look at maternal and child nutrition and health in Peru. I would like to put this presentation into context. First of all, a slide that can show us some figures, some of the measures adopted by the government, and of course the different challenges that we are facing ahead regarding this matter. Mother and child health and nutrition and child development are a good panorama to start off and to put my presentation into context. This slide has been worked together with the Ministry of Development and Social Inclusion, with which we are working at the early child development policy, in which we should all work in order to achieve the results that we are aiming at. This slide shows the first statement where we have the life stage. We have the women in childbearing age, pregnant and fetus health, delivery, mother and newborn health, child health, and adult health. Under this logic, we have a series of factors which are related to the way in which we must develop the conditions that have an incidence in this factor in order to have an adequate child development, which, if it is early, it turns into a window of opportunities for human development. So here we have nutritional status of the pregnant mother, adolescent pregnancy, morbidity due to different problems, for example, high blood pressure, delay of growth, infections in the first quarter. What happens during pregnancy, before pregnancy, and those factors that after delivery are related to delivery and which have an incidence in early childhood development. We know about them in healthy practices. Among them, we have breastfeeding, hand washing, complementary food feeding. There's supplements with micronutrients. This is all related to infections prevailing in childhood, congenital anomaly, low weight at birth, prematurity, and all those complications that we know that are related to the causes of these topics. These are all related to complications that can end up in a neonatal death, neonatal complication that can end up, mother death and complication in neonatal health, and in the case of a child, for example, low weight, anemia, which is a very important or significant problem in our country. Okay, if all of this is worked correctly, it allows the main characteristics of early childhood development, the explosion of vocabulary and executive functions, become a window of opportunities in order to have an adequate early development. But if this is violated or altered, then early development is affected, and we all know about the consequences or have been mentioned before. With respect to mother mortality, some figures. I am going to bridge what Adrian said, that yesterday was the past and today we're going to talk about the present and future, and we need to talk about the past first in order to speak about the future. So the figures that we're going to show the trend that we mentioned. Mother mortality, maternal mortality, we all know about the progress. Just to rescue some figures, the evolution in our country, according to the figures provided by the General Epidemiology Office, In 2013, 379 deaths compared to 480 in 2012, and the figures were higher in former years. The reason for this decline we don't know about. However, if we look at the same figures, the number of maternal deaths between 2007 and 2013 per departments or per regions, we will see that there is inequality in figures. There are some regions, for example, Lima, which included Metropolitan Lima and Callao probably, has 52 maternal deaths. There are other departments such as Cajamarca with 29, La Libertad 30, Loreto 29, Piura 30, San Martin 18, and there are also departments that have one, for example, Arequipa or Moquegua. Madre de Dios has 5. So the inequality between maternal deaths show a difference. Despite the progress made, there is still some room for further progress. With respect to neonatal mortality, I am sure that you have seen this slide before. Just to mention that although it is true that child mortality, the curve is declining significantly, still in neonatal death we have some figures that we must pay attention to. Chronic malnutrition, child chronic malnutrition, there is child chronic malnutrition. There is a national trend where we have met the Millennium Development Goals towards 2015. We have a more ambitious and challenging goal that we want to meet in 2016. However, I think that the main characteristics of this slide, and that we have all commented about, is the deceleration of the curve, and especially the trends both in the urban area, although in the rural areas they have continued to fall. The figures for 2013 show that this deceleration is more evident. It's around 17.5. Another analysis of child chronic malnutrition is the differentiation between the regions. Although these are figures for 2012, the figures for 2013, the trend of this deceleration is similar. This just shows that out of the 25 departments where we have in Peru, 15 still have figures above the average, national average, and Huancavelica in 2012 still was the region with greater prevalence of child chronic malnutrition. An additional analysis carried out with respect to child chronic malnutrition is the absolute figure of number of children in the regions, which changes the position of the regions when we look at absolute figures. For example, in the case of Lima, in the former slide we saw that with respect to the prevalence, Lima was placed almost last, 6.1%. However, if we look at the absolute number of children, Lima moves to the second place with 53,467 children with chronic malnutrition, which is more than Huancavelica, which has 34,601 children. So this is an analysis that has been taken into account to look at the current figures for child chronic malnutrition. With respect to anemia, it has similar behavior. However, we can carry out an analysis that forces us to make additional thoughts. If you see the figures, they fell to 41.6% and it has increased to 44.5%. However, the trend is to 46.4%, which leads us to look at this problem in detail, especially when, according to the World Health Organization, the countries with prevalence of over 40% have a serious public health problem. In the urban area, the increase is evident. In the rural area, there is also an increase. However, vis-a-vis the figures of 2013, this characteristic is more urban in areas such as metropolitan Lima and in the upper fourth and fifth quintiles. The characteristics, when we look at it on a region-by-region basis, is similar. We have almost 18 regions where prevalence is above 40%, and if we look at absolute figures, the behavior is very similar to that of child chronic malnutrition. Lima stands first due to the number of children. Some other figures with respect to coverage indicators related to health and child and maternal nutrition. Pregnant women with prenatal control in the first quarter versus those with 6 prenatal controls between 2007 and 2012, there is a growing trend. However, there is still a gap between the number of pregnant women that receive 6 controls versus the number of pregnant women that receive controls during the first quarter, especially when we look at the quality of these controls where auxiliary exams are very important. With respect to supplements with iron and folic acid, there are high figures. However, the main problem is the adherence of pregnant mothers, given that pregnancy predisposes pregnant women to anemia in the newborn. So although it's true that figures are high, the adherence is something that we have to work on and where we have to analyze some specific factor. Institutional deliveries, high figures, 85.9% average. In the rural area, the figure has grown to 67%. I think that for 2013, it's 69, something. And although the gaps have reduced, there are still many things left to be done in this matter. And together with the natal controls, prenatal controls, the cutting of the umbilical cord in institutional birth is something that we are analyzing and where we need to have more control. Breastfeeding, this is an important challenge for everyone. Although we have very good figures for 2009, 2010, towards 2011, 2012, these have fallen, mostly in the rural area. And obviously this generates a most focused intervention in this regard. And supplements with iron, and for children under the age of 3, although 50% of children have this kind of control, only 19.6 receive iron supplements, and the law states that every children that resort to it must receive iron supplements. So this is something that we need to work on. Finally, vaccination. Just one slide related to pneumococcus and rotavirus, which showed an increase up to 81.1% and 76.6%. However, there are different topics to be analyzed with figures from 2013. 3 slides related to the main actions that are being carried out by the governments in the past year or in the past months to understand these figures and to be able to improve them. At a political level, the intersector and intergovernment commitment to promote early childhood development under the strategy Inclusion for Growth, as the Ministry of Social Inclusion mentioned, together with the SIA's agenda, with which priority is maternal and child health. The design of early child development, well, the MINSA has reviewing the causal model and priority interventions, and then the implementation of sector and multi-sector plans for the reduction of child chronic malnutrition, prevention of anemia, national plan for the reduction of neonatal morbidity and mortality, and a plan for pregnancy in adolescent women. With respect to access increase, there is an extension of the coverage of the Comprehensive Health Insurance Program, SIS, the approval of the law of mother-child, in which the late cutting of the umbilical cord is important. We will start increasing access for pregnant women for natal birth control. We have improved the presentation of iron and folic acid for pregnant mother, and universalization of supplements with iron for children under the age of 3. Incentives to performance. There are some agreements with regional governments for the achievement of institutional goals, agreements between SIS and the regional governments for the payment per capita, and the fund for performance stimulus, which is led by the MIDITS and the Ministry of Economy, which have indicators of child chronic malnutrition and anemia. Educational and communication strategy to enhance practice in nutrition and feeding. Other measures in the reform. You've followed this reform closely. I think that there are important challenges that will help us meet the objectives. 2 slides to talk about the main challenges that we have identified for these topics. First, increase the differentiated services for adolescents in the health facilities and get rid of violence in adolescents, with emphasis on sexual violence. Yesterday we mentioned this topic. To improve the quality of the prenatal control, having an incidence in the start of controls in the first quarter and auxiliary tests in the first consultation, and to close institutional delivery gap in pregnant mothers, especially in rural areas, by providing better services, fostering resolution capacity for the management of newborns with complications to improve the coverage of CRED, supplements of micronutrients, strengthen strategy that promote and protect exclusive breastfeeding, ensure availability and use of the required inputs, among them iron, micronutrients, and vaccines, and strengthening intergovernment articulation and intersector articulation for the implementation of the strategies proposed. I think that it is important for the Ministry of Health to strengthen, to improve, and to organize the actions under its control, but this should not leave aside the importance of the work carried out by the different sectors in this topic. Thank you very much.